Welcome to the YMyHealth podcast, everyone. I am your co-host, Melissa Schenkman here. And on this episode, we're going to be talking about a really interesting research study. I know for a lot of people that cancer syndromes these days are top of mind in the under age 50 population, which is our community. And there's a lot of talk about what can we do from a preventative side and finding access to those tools. And this is going to be one of those episodes where you're really going to learn something new in that area, which is exciting. And we are very fortunate to have Dr. Alejandro Rauh-Hain with us and Dr. Karla Barajas, both from the Department of Gynecologic Oncology and Reproductive Medicine at MD Anderson Cancer Center. And they are involved in a really cool study we're going to talk about called IGNITE-TX study. Dr. Rauh-Hain is the principal investigator of the study. And Karla, I'm going to start calling you Karla here,
Sure.
which I'm so used to, is a research fellow on this study. And so we're very excited to talk with you both about this. And thank you so much for joining us on the podcast.
Thank you very much for the opportunity to be here.
Yes,
So
thank you for having us.
So welcome. Very excited. To begin, I think what a lot of people want to know is what does this landscape kind of look like across the country when it comes to the number of people with a hereditary breast cancer, ovarian cancer syndrome, or Lynch syndrome, which more and more people are starting to hear that term these days. Kind of what does that landscape look like in the past few years? And is there anything in particular that seems alarming about the data and the statistics you're seeing?
Yeah, so I think that when we're talking about hereditary breast and ovarian cancer and Lynch syndrome, we're talking about two of the most important inherited cancers that there are. And it's really important to understand that while they're not that rare, they're very highly undiagnosed or underdiagnosed. So the numbers look a little bit about like for hereditary breast and ovarian cancer, there's about 1 in 400 people who have the mutation. And for Lynch syndrome, there's an estimate of about 1 in 300 people. So if you really add that up, there's millions of people in the United States
Yeah.
who have that mutation. But as you mentioned, I think the most alarming part here is that a lot of them don't even know that they have the mutation. And 50 to up to 90% have not been diagnosed with that mutation. So I think it's really important. And with this study, that's sort of the main goal to try to get that number up. And I think that number matters because it's not just statistics, but it's actually like real people who could actually do something about it, knowing that they carry this cancer risk and taking action into trying to prevent cancer, which I think it's a huge gap that we're seeing with this study is that the things that we can do with genetic testing are nowhere near what's actually happening in real life. And I think we should really take advantage of that tool that we have.
No, I can really understand that because we've had so many people come to us, especially in the colorectal cancer community where people know we do a lot of work, who have later on learned after being diagnosed that they actually had Lynch syndrome. Honestly, one piece of advice they come back is like, please learn about Lynch syndrome and go get tested. Like,
Yeah.
you don't know until you know a lot of the time. And so to your point, and was there anything in particular that you saw, Alejandro, that you saw within the landscape plus within your clinical experience, with patients, that led you to want to create Ignite TX?
Yeah, I mean, I would say that, these days we're very good at testing patients that already have cancer. So if I see a patient with ovarian cancer in my clinic, the chance that we're going to test it for one of these mutations is close to 100%. What we're not very good at is testing the family members. And the reason why this is important for BRCA and Lynch syndrome is that if you identify one family member with what we call a proband with a BRCA mutation or Lynch syndrome, that means that their family members, first or second degree relatives, have a 50% chance of having the same mutation, 50
Wow.
of having the same mutation. So really, really high. So what I saw were patients of mine that, they were undergoing treatment and surgery and everything that we do for ovarian cancer. And then suddenly their family members were also coming to see me with a history of breast cancer or with a new diagnosis of ovarian cancer. And we saw that when you look at, patient family members
Yeah.
of patients that have a BRCA, they talk about this, but they actually don't get tested. So, that's what really sparked the fact that many of those family members, they knew that the original patient with ovarian cancer, had a BRCA. It's just that they didn't get tested. So this, what we call cascade genetic testing, is a very efficient way of finding those family members with a mutation, because then we can prevent the cancer before it happens.
Which is amazing. And Karla, from your clinical and research experience, what prompted you to want to play such an important role in the Ignite TX study? Um, and how did the two of you connect on the study as well? We're so
Mhm.
curious.
So, I actually I think women's health is something that I've always been interested in, and not just from a medical perspective, but also of the bigger issues of trying to get the information out there and giving access to everyone, and particularly in the underserved communities.
Mm,
So I was actually raised in Mexico, and I think one of the bigger issues I would see there is giving healthcare access to women, and particularly again from underserved communities. So when I moved to the US, that's something I really wanted to focus on, and something I was interested in, and I wanted to get involved in research. So I also think that I was interested in something about prevention, which again I think I find very important to try to tackle the issue before it actually happens.
mm.
So overall, I was so, interested in research. I came across Dr. Rauh-Hain's work, and I was very interested, and I reached out to him, and he replied, and he was very nice, and he's been mentoring me ever since and inviting me to join the study. So that's sort of how we connected. I feel like that's yeah.
That's awesome. No, I always love to hear, and I know everybody else does, how people get connected to work on something of such significance like this.
Hmm.
There's always definitely that personal interest behind it and personal experience that led you that way. So I appreciate you both sharing that with us. And as you were in the process of developing this study, Alejandro, what did you learn from prior research in the area that was out there?
Yeah, I think what is very clear is that if we diagnose someone with BRCA, let's say that I see that patient that I said with ovarian cancer, we do the testing, and now they have BRCA, it is very likely that that patient is going to tell her family that they are at risk of having the same mutation. So most of the times they will talk to their family members and say, hey, and they will say, please get tested. You have a very high risk of having the same mutation. You should get tested. So the communication that happens, it's just that family members don't get tested. And there are a myriad of reasons for that. But when you look at the data, overall, maybe 20 to 50% of the times, family members get tested. So very, very low. And
Yeah,
especially when you look at the numbers in rural areas or in medical underserved communities, those numbers are even lower than that.
I can imagine. Yeah.
Exactly. So that is, that's what sparked kind of
Yeah.
Ignite TX. This really need of how we can help patients communicate with their family members about the importance of getting genetic testing. Because you can imagine that the new family member first needs to understand the information, say, okay, now, how do you communicate that you may have a mutation? What is a mutation? What is a gene? And then, okay, that mutation is going to increase my risk of having breast and ovarian cancer. Then that leads to fear. Maybe I don't want to know. What am I going to do about it? Am I going to lose my insurance? So there are a lot of things that now the relative is thinking about and being afraid, and maybe decides, you know what? I'd rather not know if I have the mutation because I don't know what am I going to do with that. So the important thing is that there are a lot of things that they can do about it. If they have the mutation, they can prevent cancer. They can, undergo the right screening to try to prevent cancer. They can have surgeries to prevent cancer. So once we felt that once we educated both the Pullman and the family member, then we were going to see an increase in the genetic testing among the family members. So really try to diminish those barriers for the family members.
No, that's absolutely wonderful because I completely agree with you, and we're so big on that with YMyHealth, the education piece.
Hmm.
It's there's so much more value than I think some people realize to
Hmm.
and it's that barrier with the health and science and
Yep.
getting that across and all the worries you were talking about as well, um, are so common, the first things that people would think about, so it's really great to hear that that is something that was thought of as you were in the process, of designing this, and so I just wanted to kinda start there to kind of, and I know, Karla, I was gonna ask you about this, just how do you kind of explain for our listeners, those who are not as familiar with the research world, what a pilot study is and why kind of that was how you initially started Ignite TX?
Yeah, so the way I would explain a pilot study is just like a smaller, earlier version of a large scale study. I would think of it like a test run, trying to see what works in the study, what's not going to work, what adjustments need to be made. And once you turn it into a larger scale study, now you have some backup data to not just go from the start. So I think that's how I would explain it. And in the case of the Ignite TX study, I think that was extremely important. We were able to try different outreach methods to try to find the people with the mutations, and we were able to see what was feasible and applicable to the real world. So I think like it let us explore questions like, are people ready to talk about this? Are they willing to talk to their family members? Are the family members willing to undergo genetic testing? How is it, what is the best way to find, is it through like healthcare providers or genetic companies or social media? Like what's the best method to do this outreach? So I think again, by doing a pilot study, you're able to learn and adapt in real time, which ultimately sets a good foundation whenever you turn it into a larger scale study to actually have something already started with some backup information.
No, incredibly helpful explanation, and that makes so much sense. And all the types of things you were asking about as you're running through them, I'm like, "Yep." I would think about that too and wonder about that too as you're building this. And to that point, what were kind of as at the outset some of the main goals of doing the pilot study?
So we had mostly, as I mentioned, like through the pilot study, I think the biggest primary goals were to try to see if this was feasible, if we were able to enroll all of the participants that we wanted to enroll, including probans, including participants, if we were able to find those people. And once we reached that goal, we also had some secondary goals that are, I think, are very important,
Mhm.
especially when we're thinking into transitioning into a larger scale study. And the biggest one was to see whether we were actually able to get the at-risk relatives
Yeah.
to undergo genetic testing. So we wanted to start comparing. We had four different arms. We started comparing which arm worked best to try to get them to the finish line. So again, as this is a pilot study, this is not something that can be powered to draw big conclusions because it's a smaller sample size. But those secondary goals or secondary outcomes kind of serve us as a starting point to see, again, what adjustments needed to be made for the larger scale study.
Be very valuable information and kind of walk us through the study's design as a whole, for participants. Alejandro, you were mentioning before about the cascade genetic testing. So, and
Mhm.
I just want to make a note about that to everyone who's listening. And I know this was mentioned, I believe, on your site, is that less than 50% of the relatives of people who have tested positively for a particular gene mutation actually get the testing done. And so kind of if we could put that all in context as to how the cascade testing works, how the study was designed and working with that, um, and kind of how you involve both the family versus the individual who had initially tested positive too. If you could kind of walk through that. And I know that's a
Yeah,
lot.
yeah.
No, you can
So
both.
I would start.
Yeah.
So I'll start, and then I'm gonna let Carla talk a little more about the design of the study. But I would say again, I just want to emphasize why this is important. So if you have a probe, and if you found someone with BRCA or Lynch syndrome, that means that their family members have a 50% chance of having the mutation. And if those family members have the mutation, they have a significantly increased risk of having different types of cancer. So for BRCA, it's breast cancer, ovarian cancer, pancreatic cancer, prostate cancer. For Lynch syndrome, it's colon cancer, endometrial cancer, GU cancer. So these patients that have these mutations, we have strategies that we can offer them so they don't develop cancer, or at least we catch the cancer earlier. So that is why testing the family members is so important.
That makes complete
Yeah.
sense, and absolutely.
So that is why cascade genetic testing is so important.
Yeah.
So when you see what happens in clinic these days, so if you come to MD Anderson, to
Yep.
one of our clinics, and you have a patient with BRCA, newly diagnosed BRCA, what happens is our genetic counselors will give a piece of paper that explains the mutation and tells the patient that she needs to communicate with the family members and tell the family members that they need to get tested. That is currently the standard of care, because as health providers, we cannot just call family members because they might not want to know what's going on.
Yeah.
So we rely 100% on the probe and on that patient with a BRCA or Lynch syndrome to tell all the family members what's going on and that they got to get tested. That is right now how we do it in our clinics. So that's, the big schema. That's how we started.
Yeah.
And that is our control group. That is one of the arms of the study. Just what happens in routine clinical care. If you were to come to MD Anderson, if you were going to go to a different institution, that's very likely what they do. Okay. So we wanted to see whether an intervention that it's called IGNITE-TX, and this intervention called IGNITE-TX, it's a very simple, you get access to a website with a lot of educational videos. We have what we call a genetic patient navigator, someone that calls you and helps you navigate all the different barriers that you might face so you can get tested. So when we talk about IGNITE-TX intervention, we're talking about this access to education, a chatbot, a genetic patient navigator that can help the family members and also the proband, but mostly family members, to actually get tested, because at the end that is the outcome that we're looking for.
Yeah.
Okay, so that is where we started. That is the whole objective of the study, and then I'm gonna let Karla just jump in and explain to you how the study was designed and how we got the different patients into the study.
Absolutely. Well, before you jump in, I was going to say it's so fascinating how you brought the pieces together that you have in terms of the educational piece of it, because so often, I know you were mentioning video, so often everything is text and everything, or the paper, like you're saying. So I love the fact that you really are meeting people where they're at today to go about it in those different ways. But go ahead, Karla, please.
Yeah, so this whole process started, as Dr. Rauh-Hain mentioned, we had to find the people who had the genetic mutation. So for either hereditary breast and ovarian cancer or Lynch syndrome. So we started outreach, again, through healthcare providers, genetic testing companies, social media, Facebook, Instagram, community outreach. Once we found those people with the mutation, they could self-enroll in this study through the Ignite website. So it's very user friendly. They can do it on their phone, on their computer, and it takes 2 minutes to enroll. You just have to complete a couple surveys about eligibility, sign consent. Once you're screened, found eligible, then they would move forward with providing with all of their first, second degree relatives who have not undergone genetic testing and could potentially enroll in the study. So that's how we made the jump of connection from the probands to the relatives. Once we did that, then we would reach out to the relatives and let them know about the study, which they should already know by the proband. We do ask the proband to let them know beforehand as well, and then they would either decide to move forward with enrollment or not. Again, very user-friendly, the same way probands enrolled. They would complete a couple surveys, very user-friendly. Once they did that, then they would be randomized into these 4 different groups that Dr. Rauh-Hain mentioned, where the first one was standard of care. And again, they would just receive that one letter stating that their relative has a genetic mutation, and that's it, basically. And some testing information or resources if they wanted to move forward, but that's about it. And then the second arm had access to free genetic testing and counseling. So they would receive a letter with instructions on how to get free genetic testing and counseling through the study if that's something that they wanted to pursue.
Okay.
However, in this arm, there was no active follow-up from like a patient navigator, which was from the intervention arm, which was the third arm. And as he mentioned, it included the patient navigator, which through like motivational interviewing help the relatives get try to get tested and try to tailor that help to that particular person, because there's so many things that goes into that decision of pursuing testing. It's very multifactorial, so it can be emotional for some people, it could be related to cost, it can be related to family burden, it could be related to so many different things that you don't really think of. But so the patient navigator would try to guide each person depending on what encounterments or barriers the patient navigator would see they were facing. And again, that arm also included the educational videos. And then the last arm included both the intervention arm, so the patient navigator, the videos, and access to free genetic testing. So they had like the whole package. And again, they would have the patient navigator constantly calling them or making follow up just to make sure to get them to the finish line, or if they had any barriers along the way, try to help them through it.
Yeah. What a great way to be able to figure out which of these things that are all breaking down the barriers in their own way
Yep.
is most successful. I'm
Yep.
guessing this is where,
Yep.
yeah, no, that's absolutely brilliant. And I have to say, my next question for you is really as the health education piece, because they were mentioning, which I'm still super excited about. As a health educator, for me, one of the aspects of the NITX study that I think is so valuable is you have these educational modules that everybody gets to learn from. And so I was going to have you kind of delve into those a little bit and describe for us, what the different educational modules look like and kind of like what was your purpose for those and how long. Because a lot of times people think like, oh, you know maybe I need hours to look at this, or if like, and I'm curious also, are there any questions at the end? Are you testing for any type of retention of information on them as well? So yeah, if you could talk a little bit about that.
So I think I honestly really like the videos as well, because I think there's so much information out there today, which I don't think it's necessarily a bad thing, but it's also very easy to get misinformed or feel overwhelmed with all of the information that you can see online, especially. So I feel like the educational videos are helping the participants know that this comes from good sources and that it was created by people that are professionals in the area, and that the information that they're receiving is actually good information. So I think that's why they're really important. But yeah, basically, so both the probands, all of the probands, so the
Mm.
individuals with the mutation would have access to the videos, and the third and fourth arm would have access to the videos. It would be a different set for a videos for the probands and for the relatives, but
Okay.
mostly the first part would address things about trying to understand the basics of genetics. So what is hereditary breast and ovarian cancer? What is Lynch syndrome? How they could share the results with their relatives. It gives them some tools on how to do that, some journaling exercises on how to do that. And there's also a module about providing social support. So if they wanted to find associations or kind of programs that um, align with their genetic mutations so they could receive more support, they could do that. There was links to different uh, organizations and stuff like that. And for the relatives, it was mostly about all of the questions they could have in regards to genetic testing. So, what does it mean that my relative has a positive mutation? What does it mean for me? What do I have to do with that information? And it also addressed things related to cost and insurance and law discrimination. So all of the things that relatives could have questions about, and they were short videos and made in an interactive way so they could sort of be more engaged. However, I they were not mandatory for neither the program or the relative. We wanted to make it in a way that was accessible and there for them, but without the pressure of them having to to watch them and just do it because they have to. So whenever, because we do believe it's something that they have to be ready to receive that information. So yeah.
No, that makes sense. That is well, I really love that piece of this because those are so many things that when people get that information, they're looking for. Because once you take that step, like that's one step in of itself, right? To get the actual genetic testing. And I also love that feature too, by the way, that you offer the
We
free
do.
for the family and two of them free genetic screening because that's huge. Like there's no barrier there. I don't know what is. When I read that, I was like, that's excellent. But I love the fact that each one of these educational pieces are addressing the really difficult parts of what do you do with this information once you've gotten it? And how do you
Yeah.
communicate it to the family? Like people, these are really hard things to find the answer to. And so I think that's absolutely wonderful, and I'm so curious. So with the pilot study, I know has been completed at this point, and which is very exciting. And so I was curious about some of the preliminary results, even that you could share with us from that, and also very curious as to what percentage of the study participants actually used the free genetic screening and counseling that they had access to, which is so wonderful.
Yeah, so yeah, we're still in the process of like finalizing and analyzing the data, but we do again have some preliminary results. And I think overall what we're seeing is that as you scale arm one, arm two, arm three, arm four, the more support that you offer, whether it's through the free genetic testing or education or emotional guidance, removing the financial barriers, the more likely people are to get tested. So, for example, there was an approximate of 3 to 5% of relatives who got tested from arm one, which is extremely low. It's
Mhm.
extremely low. And when you go ahead and compare it with arm four, which right now you could say it's about 75 to 80% of people of the relatives have been tested. So you can see there's a huge gap in between those two arms, and there's a clear progression as you go from arm one to arm four. So I think that even though these are early results, it's already showing how impactful it can be. It can really be. And it can see that if you really meet people where they are and guide them through the process, then they can really increase cascade genetic testing.
Oh, absolutely. That's wonderful to hear that even though, like you said, those are preliminary results, those numbers speak for themselves. So, like that's really in terms of the impact of having that support and the different levels of support. I think that's awesome. And why do you feel knowing all of this now and I'm curious both of your thoughts on this, why do you feel that you need a larger study here after learning what you've learned so far? So whoever would like to take the question first, totally
So,
fine.
yeah, I mean, I think these are all preliminary. So these large studies are powered to detect differences, right? So you need statistics to
Yeah.
really prove that there are differences. And so when we design the pilot, the feasibility study, these
Mhm.
are were just, they were powered. So these populations were tiny. And just to make sure that we could run a large study that we can truly find the right answers. So for example, for this pilot study, we only enroll 60 probants. So it's around 144 relatives. So it's a large number of relatives, right? It's not
Yeah.
small, but it's not enough to statistically show a differences between the groups. So when we have run the statistics in order to show a difference, clinical relevant difference, but also statistically difference, we know that we need a study of 700 probants, around 1,400 relatives. So we need a much larger study to be able to accurately say if you are enrolled in arm X, you truly are at higher, you're more likely to complete cascade genetic testing. So it's all about the numbers and just to be able to statistically show the differences. But yeah, I mean, I would say, you know, differences between 5% and 70%, 75%,
Yeah.
it's truly remarkable. And I think we are all surprised to see such a big gap. Um, so, I think, it just speaks that there's a need for this kind of behavioral interventions to improve cascade genetic testing.
Oh, absolutely, absolutely. And Carla, in your view, in addition to that, as well, there's anything you'd like to add on this front as you were going through and seeing the study's progression?
Yeah.
Yeah, what do you see and say, we gotta make this even bigger?
Yeah, exactly. I think honestly, Dr. Rauh-Hain said everything that I was gonna say, but
Oh
yeah, so
gosh.
I think basically you can see the really big gap that there is. So it's letting you know that there's definitely a difference and that you need to do a larger study. So I think that with this, you just sort of confirm that you need more information because as you mentioned, it's a very small sample size. It's not powered to have like a big results or statistical significance. So once you know that that's important to look into, then with the larger scale, you can turn them into real, actual thing, results that will last in the future.
No, absolutely. And what would the larger study kind of look like? I know you're talking about much larger numbers, obviously, of people that you would enroll, but also would there be any changes like in the parts of the study design or how you would um, kind of go about in recruitment, perhaps, or just those types of things? And I know it's still relatively early days on that, but just curious.
Yeah, Karla, you want me to answer?
Oh, yeah. Whoever would like
Okay,
to.
yeah.
Yeah.
Yeah, sure. I'm happy to answer
Yeah.
that. Um, so, um, so it's gonna. I mean, we have had a lot of conversations about what to do in the next study, and you can argue why have an arm in which 5% of the patients' family members get tested, right? I mean, that seems
Sure.
to be perhaps unnecessary. And I think at the end, what we decided is that, and we had decided this from the beginning, that we wanted to emulate the feasibility study. That was the intent for the original study. So we just want to emulate how we got the pilot data. Again, we don't have enough numbers in the feasibility study to really say for sure there is a difference. So that's why the big design of the basic study ideally would be the forearms. And that's what we are proposing for funding mechanisms. And and the outcome would be the number or the percentage of relatives that get tested at 6 months. That's what we're looking for.
Okay. That's
Yeah.
that's that's super helpful to know.
I think I mean, as he mentioned, we were going back and forth, and there was a lot of talks around how many arms we should include and if we should remove an arm or include an arm. But I feel like at the end of the day, there was at some point where I had an opinion about it of reducing it to 3 arms. And when talking about it with Dr. Rauh-Hain, I could really see how that was not a good idea. You can really see how I really liked the results in the way that they scale from like a little bit more, a little bit more. So you can see it starts with the 5% with arm one. And then if you offer genetic testing, let's say it goes up to 20%, and then arm three goes up to, let's say, 50%, and then arm four. So the more you offer, the more that the better results you get. So I feel like it's really good to see how it can scale up because I mean, it might be hard to, from the start, kind of transform offering free genetic testing and counseling and a patient navigator to everyone. But it might be more feasible to start offering patient navigators only, and it still increases cascade genetic testing. So I think it's very important to have the four results, in my opinion.
That's an excellent point, and I can totally see with my uh, researcher cap on to see how you would see that first arm and be like, well, based on the numbers, but to be able data wise to show that and to be able to show that to other
Yep.
places around the country, everybody's got different budgets to work with, to your point, and different things, and so it really gives them more than one option to improve testing rates. So I think that's great, and Alejandro, just far as recruiting people, because I think this is going to be of tremendous interest, is kind of what types of people are you looking for in the larger study in particular? If you could tell us about that for those who are listening and who are interested.
Yeah. So for the larger study, we're looking for patients with BRCA1 or 2 or Lynch syndrome. So those are the only hereditary cancers that we are going to include in the study. Perhaps in the future we will expand it to other mutations, but as of now, those are really the focus of the study.
And what about age-wise? And then in terms of, do you need to be located in Texas, certain parts of the country? Um, what about in for those things?
So as long as you're more than 18 years old, that is the only age requirement. And
Okay.
it can be the family members, so the proman with the mutation and the relatives need to live in the United States, anywhere in the United States.
Okay. That's super, super helpful to know too, because we have listeners both in the country and outside the
Yep.
country, who will very much, I'm certain, be interested. And then in terms of the lift, this is always the question of the millennials
Yeah.
specifically, with the crazy busy lifestyle. So Karla, kind of what does the lift involved and, for a study participant?
In my opinion, I think we've tried to keep the lift as light as possible for the participants. So for both the probants and the at-risk relatives, as I mentioned, this is a self-enrollment study. They can do it on their phone, they can do it on their computer, and it's only honestly about a total of 5 surveys. Each survey, let's say, has an approximate of 10 questions, takes you 2 minutes to complete each survey, and that's about it. So I think it's mostly about for the probans, the burden of them being ready to share the results with their relatives, and for the relatives to be actually proactive in wanting to pursue genetic testing. So the overall work that they have to do to be involved in the study is really not much. So it's more about the outside part of it. And as for the arms, I think it depends a little bit on the arm that they're randomized to. But overall, maybe arm 3 and 4 with access to the patient navigator might have more engagement with the study as it's a constant follow-up. But it's it's really not much, if I'm being honest.
Yeah, it sounds like a pretty light lift to me for huge value. So that's a great thing. That's an absolutely great thing. And far as getting involved, so um Alejandro, just how can people get involved when recruitment starts back up?
Yeah, I mean, it's very easy to enroll in the study. You just have to visit our website, ignitetx.com, and it's landing page. You just have to, after that, I just want to say that you want to enroll in the study. The patient that enrolls in the study, this is very important, is the patient that has the mutation. And we do ask that that patient uploads their genetic testing. So, that family member, the proband, has to have the genetic testing available.
Okay.
But it's very easy to enroll. We just ask couple of questions about name, contact information, upload the test, and that's it. Like very, very easy. And then the contact information for the relatives. We really have worked very, very, very hard. And this is like years on the making to make it very simple for patients to enroll in the study. Like we really try to make it as simple as we can. I mean, patients still have to sign a consent, but again, it's very easy to do on the computer, by email. Like all the process takes less than 10 minutes to do. And also for the relatives, it's very, very easy to do. I would say the advantage is that you would have in 3 of the arms, you're going to get some kind of help for the
Yeah.
family members to get tested, right? So, 75% of the times you're going to get some kind of help for free.
Yeah.
And even if you are randomized to arm 1, you still get the letter and the reminder. So, that is the standard of care. Still is the standard of care, right? So, um, again, we are very motivated to look for participants. If anyone wants to join the study once we open, it's going to be very easy. We're going to promote in social media. We're going to talk to genetic testing companies. I mean, it's going to be a big, big promotional lift. But we know that from the pilot study that with all of these different mechanisms, we were able to reach out a large number of patients. So, again, if you're listeners with BRCA or Lynch syndrome, if there are anyone out there, we're hoping to open the study in the next 6 months. And again, there's going to be a lot of promotion once we are ready for that.
Awesome. Awesome. No, that's wonderful. Wonderful to hear. And Karla, why when people are thinking about this, why is participating in Ignite TX so important?
So I think it's very important because it you give back in the same way that you receive. So you're helping us trying to find what is the best way for the future generations to get access to free genetic testing and overall helping in the public health environment to try to get those numbers up in the future. So you're being proactive in science, But in that same way, as Dr. Rauh-Hain mentioned, you're also getting something back. So 75% of the chances you're receiving something out of it. And if you get to the finish line where you get genetic testing done and you know whether you or not you have the genetic mutation, then I think that's very important information to know. And it could potentially change the whole like the outcourse of your life, which I think is amazing. And you can start taking measures into thinking about earlier screenings or preventative surgeries or medications, and all of that could potentially save your life. So I think, as it might not look very important to get cascade genetic testing done, I think all of the outcomes that come with it are extremely important and could really benefit those who need it.
Absolutely, and so well said. They absolutely can. And as we wrap up this episode, I have a question for each of you, and you can decide who would like to go first. but but here it is. What are each of your hopes for what the research findings from Ignite TX can do in positively impacting preventive care for millennials? In particular, and solving kind of current problems that you've talked about a little bit in the healthcare system when it comes to early onset cancers.
It's okay, Karla. I'm gonna let you take this one first.
Okay.
I'm curious to see what you're
So
gonna answer.
So personally,
Yeah.
I think my biggest hope is to try to help shift the focus of the healthcare system into start being more proactive in the preventative measures. Because I think I feel like that's the most important part. Like the way we now have tools to try to not treat cancer when you have cancer, but to prevent it altogether. I think it's an amazing tool that we should take advantage of, and it's just not talked about enough. So I feel like that's really important for future generations with increasing rates of cancer overall, that many of them don't realize that we have these tools that could again potentially help them save their lives and not develop cancer altogether. I feel like we should normalize having conversations about family history, and we should normalize having conversations about hereditary cancer and try to change the narrative about how we look into what hereditary cancer is. I think
Mm.
that's what I hope the most.
Yeah, no, that would be absolutely wonderful. We need that so much.
I
For
know.
We really do. And what about you, Alejandro?
I think just to emphasize and echo what Karla said, that we really want to raise awareness about the risk of hereditary cancers, and that we have a very effective strategy through cascade genetic testing to identify at-risk relatives. And if someone is diagnosed with BRCA Lynch syndrome, that we have very, very effective strategies in order to decrease the chances of someone with a BRCA or Lynch syndrome on developing cancer. So it is much, much better to prevent cancer through surgeries, screening, than waiting until a patient develops ovarian cancer, in which the prognosis many, many times is really poor.
Yeah. Very, very, very true. And we're so grateful that you have designed Ignite TX to do that and to have uh that evidence and really, change, as Carly was saying, the narrative when it comes to genetic screening, and especially for both those who have a mutation and for their family members, and the number of lives that this will save. Uh, just want to tell everyone again that if you are interested in joining the study and following the great work, definitely visit ignitetxstudy.com. And they're also on Instagram. I know lots of you are on Instagram. So at Ignite Study TX as well. There are no spaces in there. And we'll put those in the show notes. But this is just wonderful work that you're both doing. And I'm so appreciative that you took the time to be with us. So, Karla and Alejandro, thank you so much.
Thank you. Thank you so much for having us.
I think
Thank you so much.
you're so welcome.